Hey there, this is Nicole, the host and producer of the Found Down podcast. Woo! I'm back. I made it back from Morocco, made it safe and sound. We had such a great time on our nurses retreat. It was a magical experience, and it was so good to get outside of the United States. Everybody got an opportunity to unwind. It was phenom. It was fun. It was such a great time. If you are interested in going next year, you should go over to unwoundretreats.com and sign up on the email list to make sure that you get looped in about what's going to happen and when that's going to be. Thank you for putting up with my absence. For those of you that listen to the show every week, I appreciate you for tuning in, and we'll be back to our regular programming. So I appreciate you. If you want to support Found Down, one great way to do that is to rate and review and subscribe on whatever platform you listen. It certainly helps the podcast go up the ranks. It helps its visibility. So if you haven't done so already, go ahead and rate and review. I would so appreciate it. Leave an honest review on whatever platform you listen. Thank you in advance. Now I want to talk about our amazing sponsor, Nicole Kupchik, CNS and educator. You know, I talk about her a lot on the show, but I really do believe in what she's up to. She has all kinds of courses where you can get CEs, such as like the CCRN review certification course, the PCCN certification review. She's got cardiac boot camp, cardiac med certification, dodging delirium, hemodynamic monitoring, mechanical ventilation, and stroke review. She has a bunch of books also available, and she does a lot of online webinars and Zoom courses. So if you're interested, go over to NicoleKupchikConsulting.com and check out her products and resources available for nurses. You can get CEs, and you can learn, and you can improve your practice by getting to know what's current out there. So go over to NicoleKupchikConsulting.com, and you can use the coupon code FOUNDDOWN20 at checkout. That's found all lowercase FOUNDDOWN20 to get 20% off at checkout. All right, that wraps up the business side of things. I'm really excited for you to listen to this episode with Emily Topolanczyk, a nursing supervisor at a local COVID-19 quarantine facility. Enjoy. Welcome to the Found Down podcast. This is a podcast of untold nursing stories that are sometimes hilarious, dark, insane, and anything in between. As a warning, this show is rated E and is mature in content. It often deals with the reality of life and death and how we as nurses intersect with that on a regular basis. If we laugh, it's not out of disrespect. We love what we do and have every intention of continuing to do so. With that, enjoy the show. Well, hello and welcome to the Found Down podcast. I'm your host, Nicole Johnson, and today I'm so stoked because I'm talking to Emily Topolanczyk. She's a new nursing supervisor at a local COVID-19 quarantine facility. So I brought her on the show to talk to her about what that's been like. She started this job. She took this job in addition to her other job as an acute care nurse, but I'm really interested to hear what this work has been like, how it's impacted the community, and what she's gleaned. But before we get into anything, how are you, Emily? And welcome to the show.
Thanks for having me on here. I am so honored to join the storied people who have been on your podcast, and thank you for letting me share. I like your question because you were like, how are you doing really? And, you know, I would say that, gosh, like sometimes I am so tired. But I would say this job is also so much of part of my like social circle now. Like there's a real community at work and also outside of it. Just so we can like debrief with each other. And yeah. Sometimes it's kind of like a baseball game at work. You know, sometimes it's smooth sailing, everything's going well, but then like you gotta hustle because like the home run is coming or something is happening, so you're hustling. But Otherwise, yeah, just doing well, rowing with the flow, going down the river.
I just want to share with the audience out there, Emily legitimately has 2 full-time nursing jobs. I don't know how. I don't know how you do it, but I am in awe of what it is you're doing. Because you work as an acute care nurse, and then you also have this really amazing job as well. How, I know we didn't talking about this, but how are you finding your balance and all of that? Is there a balance?
Um, well, like realistically, no. The things that I used to do when I only worked one job, I don't do. Like I don't go out hiking. I don't go for long vacations. I've switched to being able to like invest almost 80% of my income over the past
Wow.
year and a half. So that's making me feel really good. My goal is to be work optional within like 3 to 5 years, and then just work when I want during like the flu season, or you take a travel job for like 6 months out of the year, or a cruise job, something like that. So that's the ultimate goal and like reason why I am working so much. But also when the pandemic hit, I didn't want to socialize. Wasn't sure what I should do. And when this extra opportunity popped up, I was like, all right, let's hop on that. And that has become like a huge part of my social circle now.
That's great. So you're
Mhm.
getting a lot out of it, it seems.
Yeah, a lot of networking, a lot of connections, learning so much, learning like the side of public health nursing, program management, just like overall operational improvements. It's it's a very different side of, you know, just improvement processes as well.
Cool. And how did you get involved with, like, when you saw this opportunity? How did you decide, like, oh, I want to work at a COVID-19 quarantine facility?
I tested it out first.
Okay.
So Um, usually, every county around the country has a medical reserve corps. It's like a group or a basket of medical professionals who are able to be deployed to a response, usually like locally in the county if there's an emergency. Um, so our local Medical Reserve Corps put out a call for people who they needed more staff at these facilities. So I had joined in 2014, did a couple of like local missions with them.
Mm-hmm.
I'm a ham radio operator with them. So I signed up for a few shifts, did some night shifts, and was kind of shuffled around to where they needed staff, and saw how the flow was, and gosh, this is super interesting. And we have nurses from all different walks of life, all different areas of nursing, like pediatrics, ER, home care nurses, wound care nurses. So it's a meeting of the minds. Everybody we're all here for our different reasons of being curious and being gung-ho about it after we try it out. And everyone has just so many different skills to bring to the table, so it's fun to bounce ideas around of like what we should do. Our scope of practice is limited. Our function is to help people quarantine safely. So that could be 10 days, it could be 14 days, it could be only 3 days because they've been in the hospital and they still need to quarantine for 3 days before they go wherever they go. But whatever they need to quarantine safely, that's what we do. And outside of that scope, we don't have an outside scope of that.
Because these
But
folks should, like, in theory, not need, they're just like civilians in a hotel, sort of, or they're just in a place where they are convalescing a little bit and like, but you're not supposed to
yeah,
be like nursing them, right? Because then that goes into like, oh, you got to go to like
to
a
a
hospital,
higher,
a higher level of care. Got it.
yeah, exactly. So we serve, right now, a lot of our individuals, we usually about get 80% of our population is unhoused. So maybe they're coming from jail and they need a shelter, or they're coming from a shelter, or they're coming from an ER and they're unhoused. And we will do our best to set them up with shelter. But otherwise, we expect them to be independent in ADLs, independent in transfers. So they could use a walker, a wheelchair, as long as they're independent in using it. And their SpO2 needs to be above 93. If it's 93 or below, they got to get shipped out.
Got it. Okay. And are some of these folks like not positive and just like waiting to, yeah, so some of them are positive and some of them aren't, right?
After the vaccines came out, now if an individual is fully vaccinated and has an exposure, they do not need to quarantine. But previously, um, earlier this year, like January, February, our policies and procedures, like per the CDC, where if you did have an exposure, you do need to quarantine, usually about 10 days from your exposure date, unless someone developed symptoms.
Mm-hmm.
So if they were symptomatic, they were tested at that time. And then if they tested positive, it's 10 days from the symptom onset date, or 10 days from positive date if they're negative. So we follow the CDC guidelines as they evolve.
Mm-hmm. Now for the folks that, so, but most of the folks that are positive, is that right?
Yeah.
Okay. Do you ever have any fear around that? Like, did you ever feel like, I mean, I know a lot of nurses out there have worked with COVID positive patients now, but like, how was that for you?
Early on, like early 2020, April through June, I would say, our exposure time to our guests is not long. We do most of the assessment over the phone. How are you feeling? What do you need? Where do you plan to go when you leave here? And then our in-person assessment is vital sign check, and then, bullshitting and being human with them. So usually that's less than 15 minutes. So I wasn't worried and we had enough PPE. We were reusing masks, but we didn't run out of things. We had we still have gowns that can be laundered.
Oh, okay.
And then but later on, when we learned about the COVID long haulers, that's when it really set in. Like, you're really thinking about infection control. Once I got vaccinated, like, I felt so relieved. But you can't get sloppy. You can't let your guard down. Even now, some guests will come up like close to the staff area. And hey, like, they can wait a few more minutes until I put my goggles on or like put my mask on. Now we all have these fanny packs with our PPE in it, so it's right on our person. Because sometimes people want to talk, people need to get something off their chest when they just came from smoking outside, something like that. So I'd say, my fear has fluctuated, but I'm still like an anal stickler about putting on my PPE, no matter like, because you never know what the conversation is going to turn into, and you don't want to like make them feel that they're unimportant. So I
Yeah.
try to always.
I'm just thinking about, man, so you probably are maybe the only human interaction that they'll have, right? For
Exactly. Quarantine is hard. It's not for everyone, and a lot of people come from a congregate setting. So they're in a shelter. They can have someone else watch their kids for a while so they could take a break. Or, they can interact with people whenever they want. Here, they're either in their room taking a bath, which we have bathtubs. I think that's great. Or they're outside smoking or outside like pseudo smoking and walking around. But yeah, the human interaction during quarantine is essential. Some people really need it, and they want to talk with behavioral health that we have on staff, and or they'll talk for a long time when we come to the door, tell us what's going on in their lives. Some people have a lot of drama going on, a lot of trauma from the past that they've experienced, things that they're worried about that they spill to you. But then, sometimes we get individuals who do love the solitude, and that's what they need, and it could be a rejuvenation for them. But yeah, you bring up a good point, especially for our younger guests. It's a tough situation.
yeah, I mean, are there so it sounds like there are sometimes families all in one room?
Yeah. We have family shelters in the area, and if there's an exposure at the shelter, or if someone is positive, the county has a mobile testing unit that will go around to different shelters when requested. So we'll often get a few intakes from the same shelter after an exposure. So, there could be families of up to 8 in 2 joining rooms, or I've had family of 5 in one room, or like a single parent with the kids, and that's tough.
Mm-hmm.
I think we need to get that from a more holistic perspective, because, and especially, that person needs more resources, that person needs more time outside. We can provide toys, coloring books, like words, to help. But
So
especially for people like who are still developing coping skills, and I think that's where our behavioral health staff really come in. I'll talk about wraparound services that we provide a bit later on, but we really want to provide so much support that we can to those individuals, to everybody.
now who like did these facilities exist, or were these facilities that were like hotels that are co-opted now by the county? Like, can you talk a little bit about how these facilities got implemented?
Mm-hmm. So early in the pandemic, they began with assessment and recovery centers. So other towns kind of lent land where not where structures could be placed that had a bunch of cots with privacy and bathrooms in them. The idea was that those sites would offload individuals from hospitals, that they would take individuals who did not need acute care and didn't need to be in the hospital, but needed to be watched. They could go south, but they didn't need to be in the hospital. It was a way for them to convalesce. Ultimately, I don't know why those ultimately closed or went warm, and they decided to move to leasing and purchasing motels in the area. From an infection control standpoint as well, it's safer. The doors open to the outside, and there are green spaces for people to be able to go outside to smoke, walk around, stretch your legs, get some sort of exercise while still being safe and within our field of vision. So originally, the county had 2 assessment and recovery centers that then went warm or closed. And then they had 3 different isolation and quarantine sites. Currently, they are down to 1. I think it's an 80-some bed facility. And we could always add more cots in there. And for anyone who needs to be off site, they can stay in another hotel or motel room. We kind of, it seems siloed. This is so new, right? There's no, from what I searched, I can't find like an association of isolation and quarantine centers. I'm sure there are. I read about one in Miami. Miami used nursing homes for people from other nursing homes who tested positive to go into. They had like a COVID-centered nursing home. That was their model. But I just think it would be so interesting to have kind of like a centralized repository where different centers share what they're doing and share their resources.
Yeah. What are the what is your sort of impression of the facilities that you're at? Do you feel like it's robust enough for like the need? Or, sorry, let me back up. Do you feel like we have enough room for folks who need the space? Or do we need this? It's just an aside question, but do we need more room for folks out there? Or are you?
As it currently stands, oh yes, we have room, and it is such a robust, quality control and such a robust offering of wraparound services. I will say, we take individuals who tested positive in an ER or at a shelter, or, from another testing site. But, something that we also have to think about, anecdotally, testing rates have decreased. So that also affects our intake as well. So if we did have a more robust, testing rate in the area or in the state, right? I think, I hope we would get a lot more individuals who needed these services. So it kind of depends on that. There is this like supply chain, if you will.
Yeah. That's interesting. You're right. They got to know who's positive, get a first test, then know who's positive, and then you can get folks to the right place. Can you, let me switch gears a little bit and talk about the UW did a impact study on the quarantine facilities on like the impact on infection and community spread. Can you talk a little bit about that? And obviously no pressure to spout the data right off of the top of your head.
Sure. And I think this is accessible on YouTube. If you guys search, let's see, it's an innovative solution to an unprecedented challenge. 4 graduate students did an impact study from March to December of 2020. So they were using that time era of data to see what impact quarantine facilities had on the greater community. Because with this model, we really serve the local community. We're not taking many travelers. We're not taking people from outside. So it really is like community impactful. So they were 4 graduate students. So look up that title on YouTube.
I'll link it up.
Oh, great. Thank you. So they did a little bit of history of why quarantine facilities were implemented And I don't know what modeling strategy they used, but they looked at the rate spread, and then they did 4 different models from very conservative to least conservative, and they looked at that like rate of spread across generations of infections. So, like sometimes people can quarantine for 10 days or 7 days or 4 days. Depends. Some people don't quarantine successfully and leave, right? So they found the 2 of their outcomes were like number of cases prevented and then number of hospitalizations prevented. So the most.
That was so cool. I loved looking at that. Sorry. Keep going.
Oh, it's like such a relief to see, these were like tangible numbers of like, oh goodness, like we are having like a greater impact. We see it one by one with people who like are no longer symptomatic, or we see people who finally have a place to go, or they have all their questions answered, or this with the vaccine, we've been able to, when we discharge individuals, we have the transportation, take them to a vaccination site. They get vaccinated. The transportation waits for them after their appointment, and then the transportation takes them to their final destination.
Oh my gosh, that's amazing.
I know.
That is amazing. That is amazing. But let's go back to the numbers though, because I read this and I was like, this is so awesome. At a minimum, the conservative amount of like infection prevented was like 2,000, almost 3,000 cases, right? To upwards of 20,000, right? 25.
Yeah.
That is
almost 20.
So cool.
I know. Yeah, and like being on the ground, the data that they're using is only so good as what we on the ground input in the chart to like give them to the data to work with the demographics, or making sure everything is in the right place. So like realizing what can happen on the ground with data quality. And then, so their most conservative was like 5,000 cases prevented, and then least conservative was almost 25,000 cases prevented, like just in that short amount of time from March through December. Hospitalizations was great as well. Least conservative, like 300 hospitalizations prevented. So, and then the top number was a little bit more than 1,000 hospitalizations prevented. So, yeah.
That's amazing. I mean, we would feel that. We would definitely feel that extra burden, because there, as you know, there are only so many hospital beds, and of those who could have been hospitalized, that so many of those would have been ended up in the ICU. So, I just want to say, like, it's just cool to look at that data and just say that obviously is why you're doing the work that you're doing, right? Because you're helping the greater good by keeping people safe. Just feels good.
Yeah, it does feel really good to have that bigger picture, because sometimes our scope is so small. So to see how these can impact hospitals and impact like the rest of the community and decrease community spread, ultimately, that's our goal. So it looks like we're hitting it.
How has it been for you lately? I mean, so obviously we're on the down tick of the Delta wave. Can you feel it a little bit? Like it's not so crazy?
The census has been decreasing. Maybe July through September, we had almost a full house all of those months. But now we're on the downturn. Originally, when individuals came with what we assume is Delta, right? It's like 80% of the lab tests now. People came in with all the symptoms, all of them. Like we were like checking everyone down. So a lot of symptom management. but now not so much. So it definitely comes in waves, and it makes us all like think about our job security as well. Like, we know this is temporary. Like, we have end dates. I think this particular location may be funded through March, but you never know. It just depends on the fluctuating need. So maybe an uptick in January after the holidays. So you never know.
Oh, I hope not.
No, it'd be really unfortunate.
I hope not. Can we talk a little bit about you? You mentioned in the beginning of this episode that there, like a lot of it's like playing baseball, and like occasionally you have to go run because you have to go catch the ball, because you're gonna do a home, like there's gonna be a home run. When is it like you're like, can you give an example of like a things got a little nutty and now you're on.
Yeah. So we know what we have to do throughout the day, and we all have our routine of how we check in. And when that is deviated from, it can affect the care we give to others. Right. So, for example, we use a harm reduction model. This means that we can have individuals on managed alcohol plans. We don't want people to, if people are detoxing and experiencing withdrawal symptoms while they're sick or symptomatic or positive, we just want them to be as safe as possible. So we can support them in using their consumption of choice, whether that be managed alcohol, whether they need to be put on a boob pathway, Suboxone, or if they choose to keep using their substances, we can give them harm reduction kits, like a clean hit kit. So
that's really cool, by the way. I like that that's the model, because that's how you're going to keep people quarantined. It's not your job to say, hey, this is the time you're going to quit drinking or quit using.
No. And we meet them where we are, where they are. It's a time for all of us to think about our bias as well, and provide non-judgmental care for a lot of our population. Maybe they haven't had the greatest interaction with healthcare providers. So we just provide a moment for them to relax and not receive judgmental care. But sometimes for those times when the home run is coming, or when you find yourself running around the field, I think it happens with a lot of boundary setting that needs to be done with some of our individuals. We'll have individuals who leave against medical advice. They need different coping strategies, and the ones they have aren't successful or aren't working for them at that time. I remember one night I got a return from a hospital. He was sent out hypoxia, and he came back in the rig. And I didn't know that he was coming back. He was a surprise. So I didn't get report. And I'm looking at the vital signs from the EMTs, and I see UTO on the oxygen. I was like, oh, what's UTO? They're like, oh, unable to obtain, we tried 3 different oximeters. We just couldn't get the oxygen. I was like, what? Okay, you put yours on, I'll put mine on, and just keep inside there. And I got 63% and they got 43%. I was like, put oxygen on now, please. He went up to 83%. And then he's getting up, but still in the low 90s. So he wasn't at like per our protocols, he couldn't stay with us. So unfortunately, I had to send him right back to the hospital. So we have those things that don't really meet up with hospital requirements. You know, if the ER is like, oh, he's at 93, 92, he's fine per their protocols, but for our facility, we can't accept that. You know, I remember another incident. We had a little fire starter. A young man came to us, and you know, he came from being admitted. He was taking his meds, and this is again where I'm like, okay, patient-centered care first. First thing he asked me for was a cigarette. And I was like, sure, like, I'll get you a cigarette. Let me take your vital signs first, because I didn't want him to have like elevated heart rate, elevated blood pressure after he's smoking. But that's a situation where maybe I should have just given the cigarette and waited 30 minutes to do the rest of his intakes. He could like chill out, calm down.
Yeah.
You know, so after the assessment, he wasn't really cooperative, didn't answer a lot of questions, asked to stop it. And he was going outside to the smoking area. I was like, all right, I'll meet you and I'll bring you cigarettes. And next thing I know, I hear like cars screeching. He jumped the fence, like he's trying to go buy cigarettes or something. I'm like, oh, okay. I'm like, I have the bag right here. Come back. I'm like, no.
I got your cigarettes. Oh no.
Anyway, so we couldn't do anything. He's off property. I'm like, okay. I told the security guard, like, please let us know when he returns. So he does, and he's like all ripped up, and his clothes are ripped. He's bloody. He's bleeding. He doesn't let me assess him. I'm like, I'm worried about you.
Wow.
I didn't know what to do. So anyway, he goes back in his room. He leaves AMA by jumping over the fence like 2 more times. Each time comes back and presents very differently. But ultimately, like he needed some rest. Something was going on, you know. Then I found out. I called the hospital to figure out, like, hey, like, how do I be successful with him? Like, what does he respond well to? And then they let me know that his meds were coming by courier in the morning. I was like, oh, okay. Thank you so much, courier. That'll be great. Anyway, this individual ended up setting a fire outside of one of our exits, like a staff exit. It wasn't our only exit.
Yeah.
But still, he was ITA'd after that incident.
ITA'd, what does that mean? 86?
Committed.
Oh, involuntary committed. Okay. Oh, okay. Okay. I mean, that's fair.
You know, a danger to self and to others. But that's where we found out, like, he was involuntarily committed 4 times this past year, and we didn't know about it. So sometimes people use different names, or we don't get the full story for someone to be successful. But ultimately, that wasn't a great fit to be at the site.
Yeah.
You know, you have things like that where it's just a lot of boundary setting. I remember when I first started, like back in May 2020, one individual kept asking for cigarettes, like one at a time. And we're like, no, like this is affecting other people's care. And then it pisses this guy off because he's waiting longer for something that he like physiologically needs to settle.
Right. So
we got okayed to buy a bag of tobacco and rolling papers. So it's like, and I'm thinking, oh my goodness, you know, my mental health clinical professor, like, would she be proud to know, like, I am having the boundary setting talk with this guest by providing him a bag of tobacco. Hey, you need to ration yourself. This needs to last you 7 days. Okay, sir. All right. So figure out, you know, like what you usually need, and like unfortunately, like the single cigarette option isn't available to you, but look, you have this big bag. Okay, now do you need like some little baggies to help portion it out for yourself? Okay, so, you know, do things like that. That's like outside of your comfort zone, but you know, now it's in my comfort zone. And I
Yeah.
could train other people, and you know, we're just rolling with it.
Just roll with it. I I want to talk a little bit. So there, like you just alluded to, there are some folks that don't want to stay and they go. And then what's your like? Are you like, okay, well, I guess they're gone and hope. I mean, I know obviously out in the community there are folks out there who are positive, right? There are a lot. I mean, that's just the reality of life right now, and either whatever. Anyway, what do you do you do anything if they leave and they're
Yeah.
positive?
We try to incentivize them to stay. So we could say, you know, if you stay until the end of your quarantine, we can give you a tent and a sleeping bag, like if they're on the street. Or say, you know, like stay one more day, let's try this other shelter. But if that ultimately doesn't happen, we'll try to give them transportation to wherever they want to go to. Some people like can't wait for that transportation to come. So they'll walk or take a bus. And ultimately, we do have a duty to warn. So wherever they might have come from, a shelter or some other congregate setting, we'll call them and let them know that individual might be on their way. And just give them information about when the quarantine is over for them, so they know that we accept them. But so I want to be clear that guests are incentivized to stay by receiving a letter at the end of their quarantine. So it's a letter that states all of their dates, positive, negative, symptom onset, discharge date. And with that, congregate settings will accept them because they know that they're no longer contagious.
Right.
So that's one incentive. Plus, like, you know, the symptom management, having people who are nice and not judgmental, and you get 3 meals a day and you get snacks and you get a big bed and a bathtub to yourself. Like that, you know,
Yeah.
sometimes hierarchy of needs are fucked up. And for some people who, you know, who are like needing something else.
Yeah. I mean, yeah. One thing I haven't really talked about is like, obviously, they're sick. Well, a lot of them are sick. Like they need help. Like they're not feeling great, and you, yeah, you alluded to symptom management. So I mean, none of these folks have IVs probably. So it's just like, do you give them Tylenol? Do you give them any kind of anything like that?
Yeah, we have a bunch of over-the-counter medicines. You know, from like Tylenol, ibuprofen. They'll double up on that. If they're constipated or having diarrhea, we can treat that. We have Pedialyte for the kids. You know, eye drops. Just everything that you would find like in a local over-the-counter pharmacy. So, you know, for a lot of our individuals, like it, you know, it sucks to be sick too. And then with this Delta, people were having the gamut of symptoms and they felt like shit. And, you know, that affects their interactions as well. So I just let them know, like, they're like, I don't want you suffering. So please, like, call us, tell you how you're feeling. If you're feeling better, if something is getting worse, like just let us know. But we're still going to check in with you twice a day to check on those symptoms. You know, and if we have some really great providers who are available to us on call. So if someone is experiencing hypertension, we can easily transport them to a higher level of care. But we've also had our providers order some hypertension medicines for them to get through quarantine before they follow up with a PCP outside. And sometimes that's us like printing off a bunch of different like local clinics with phone numbers that they could call to set up an appointment, and linking them to a lot of community resources that are in the area so they do get that follow-up care.
Let's talk about those services, those wraparound services.
Okay.
What are they?
So,
Or, I mean, or however you feel comfortable talking about it. But
so that's us with nursing, right? And we also have behavioral health staff. Some are like licensed counselors, and so their function is to make sure that individuals have a location to discharge to. So they're doing a lot of calling around to the shelters, finding beds, finding space, but they're also helping people sign up for EBT benefits, housing benefits, and we can print off the applications. We can fax the applications for them. Sometimes we'll have veterans come through, and we're able to get them linked with case managers there to follow up on housing or something else. So, even that those are my teammates who are able to like print off coloring things and give it to kids, so mom has like some time to relax, right?
Yeah.
But yeah, we do so much behind the scenes, linking people to resources. Everybody is really a busy bee, and I see so many people like going above and beyond of like, what does this person need? They have a recent bipolar diagnosis. Let's get them into like community meetings about it so they could have people who they could talk to about it, and like peer counselors. So, we live in a really great area with a lot of services. So we're lucky to be able to like have things in the community that we can link them to. So, and we're lucky to have like the staff that we have that know these things and can link people.
That sounds like a great place to work. It sounds so fun, actually, as you were like talking about like checking in on the guests, and I mean, obviously it's probably hard too, but if you're like checking on them, making sure they're set, got what they need, that they're safe, that their vitals are all right, and it's like, okay, well, how can we help you get through this? And yeah, it sounds like a cool place to work. I know you said who knows if the contract, currently your contract, the funding will be up in March, but we'll see what happens. Is there a way that we can get involved in the community, or is there a way to help, or is there anything you want us to know about the work that you do?
If you'd like to get involved, you can check out some staffing agencies in the area to see if they staff quarantine facilities, and check out your local county medical reserve corps.
Yeah, that
or
is
if they
so
have
cool.
a public health.
I want to write that down and put that in the show notes. Medical reserve corps.
Yeah, there's an orientation you need to go through for the medical reserve corps. And some counties have public health reserve corps, and part of the orientation is to take some FEMA courses. So you're familiar with the National Incident Command System for how communication happens during an emergency. But there's so much training available. They really like train up and manage up. So those are two ways to get involved. But yeah, I really love being in the public health side of nursing. It's very human. There's time for so much more interaction with people, like on a different, like one-on-one level. Especially, I've learned so much about harm reduction here, checking my own bias. You have people who use drugs in all walks of life. Orthopedics has different drug users than maybe like plastic surgery than the individuals that I see.
Yeah.
Yeah, that was really interesting. And I love meeting people where they are. I love this new language that I know how to use now, like with harm reduction kits, or like asking like the frequency or amount that people use, and using the lingo just opens up a whole new world, makes rapport very easy to establish, because people know that you know a little bit about their world. And sometimes I'm still vulnerable with that. I'm like, what does that mean? Yeah, just everybody is going through their life, right? And I guess my message is like, just to use trauma-informed care, like with everybody that you encounter, like with your patients, like think about what might have happened to them, just like with your family members, think about what they're going through and how that affects them in their presentation. And, we're just here helping people go down their road.
I love it. I love it. I love it so much. It makes me so happy. I'm sure, I don't know, it just feels like that's really good work, really good, heartwarming work.
Mm-hmm.
And it sounds so cool. You learned so much. You learned about yourself, and it's informed your practice, and it will probably inform I'm sure it already does, informs your practice at the bedside when you're doing inpatient work. Yeah, you're so cool, Emily. Thanks for sharing all this on the show. I've like got like this image in my mind of you using the ham radio, because you mentioned that you did that with the medical reserve. Like, that's so cool. Any closing thoughts for the show today, or did we not touch on anything you wanted to talk about?
No, I think we gave like a nice overview of what we do in quarantine, of like what we do public health wise. Yeah, just we're thank you for letting me present a little bit about, we're all in this like supply chain of pandemic.
Right.
So thank you for letting me share this little part of what happens in pandemic work.
Yeah. Yeah, no problem. It's been great. It's fun to see you again, and via Zoom. And yeah, I should ask you, are you on social media, and do you want me to tag you?
Yeah, I am. My Instagram is yawar.miski.
Yawar.
It
Can you spell it?
YAWAR.MISKY.
Just like it sounds. You're right. Yeah. Yawar.miski. Yep. Cool. Well, if you want to follow what Emily's up to, follow her on yawar.miski. She'll be tagged in the post. Also, I'm going to link up the impact study, the Medical Reserve Corps, and maybe a link about quarantine facilities in the Seattle area. So fun to talk to you. So meaningful. Thank you for doing the work that you do. You're a gift. And I love what your mission is. Hopefully you can just work sometimes in a couple years. I love it. I love it. You're young. I mean, and also, yeah, it sounds like a fantastic plan. And yeah, I'll just close this one out by saying stay safe and stay sane. And we'll see you on the next one.
Bye.
Hey, that was so fun. You did such a great job. I loved it. Thanks so much for tuning in today. If you enjoyed the show, please subscribe and leave an honest review on whatever platform you are listening. Also, feel free to share this with your nursing colleagues. If you'd like to email me, you can do so at founddownpodcast@gmail.com. Feel free to send in any stories. Just make sure they're HIPAA compliant. Also, you can follow the podcast on Instagram at founddownpodcast. We'll see you on the next one.